Welcome back to the deep dive, where we take your sources, the research, the notes, the articles, and really unpack them. Today, we're doing a major deep dive into a huge medical topic, dilated cardiomyopathy, or DCM.
It really is a sprawling field. When people think heart failure, they usually picture a heart attack, a blocked artery.
A plumbing problem, basically.
Exactly, a plumbing problem. But DCM is different. This is a muscle failure. The main pumping chamber, the left ventricle, gets big, baggy, and weak, and it just can't pump blood effectively.
And the mission today is to dig into the why. The reasons are just staggering. We're not just talking genetics, we're talking about poisons, life-saving medicines, even just intense life events.
And that's where the sources get so interesting. Because despite all these completely different starting points, a toxin, a virus, a metabolic issue, the heart almost always ends up looking the same.
It progresses to a predictable endpoint.
It progresses into what we call a convergent clinical phenotype. The weak heart tries to compensate. It kicks on hormones, it gets thicker hypertrophy, and you get secondary problems like leaky valves.
So it's like forensic work for a clinician, trying to find the original clue when all the crime scenes look the same.
That's a great way to put it.
Yep.
But here's the crucial thing, the hope we need to start with. Those secondary responses, they're often modifiable. They're reversible.
Really?
Yeah. The data shows that nearly a third of people with new-onset cardiomyopathy, if it's not from coronary disease, show substantial spontaneous recovery. Their heart function can go back to normal.
But that all hinges on finding the root cause.
It hinges entirely on finding and removing that root cause quickly.
That's a powerful incentive.
Let's unpack this. Let's start with the things people administer themselves, the lifestyle substances.
Right. And the biggest one in that category, according to our sources, is alcohol. It leads to something called alcoholic cardiomyopathy. What kind of intake are we talking about? This isn't just a glass of wine with dinner, right?
Oh, no, not at all. This is chronic, heavy consumption. The research points to about 60 to 80 grams of pure ethanol a day for 5 years or more.
Give me a real-world equivalent of that.
That's like 6 beers.
Yeah.
Or an entire 750 milliliter bottle of wine every single day.
Wow.
And we have to note, women can develop it with less, and even just frequent heavy binge drinking might be enough.
Many of these patients are what you'd call fully functional. They have jobs, families. They don't show the typical behavioral signs we associate with severe alcoholism.
It's a silent disease then.
Very much so. It's this
Yeah.
quiet, slow erosion of cardiac function.
And when it's finally found, the damage isn't all permanent, is it?
No, and that's the key distinction here. The sources are clear. The impairment is a mix of permanent scarring, which you can't get back, and a really substantial component that is actually reversible.
Reversible how?
With complete abstinence, even in a patient with severe disease, you can see marked improvement in just 3 to 6 months. But, and this is a big but, if that heavy drinking continues, the prognosis is grim.
And there's a warning sign, the specific one, atrial fibrillation.
Yes, AFib, that irregular heartbeat. It pops up both early in the disease, they even have a name for it, holiday heart, and in the more advanced stages. It's a huge red flag.
Okay, moving from alcohol, what about stimulants? Cocaine, amphetamines.
A very different mechanism, but just as destructive. These are what we call catecholaminergic stimulants.
So they flood the body with adrenaline-like chemicals.
A massive surge. And that causes chronic cardiomyopathy over time, but it also creates all these acute, immediate dangers. Stroke, malignant hypertension, aortic dissection. I mean, life-threatening events. But when you look at the pathology, the heart muscle itself, it tells a fascinating story.
What do you see?
You see microinfarcts, tiny, tiny areas of dead tissue. It's consistent with small vessel ischemia, where the smallest blood vessels clamp down and starve the muscle of oxygen.
And with cocaine specifically, there's another layer to the damage, right? It's not just about the chemical rush.
That's right. The sources point to thrombosis, so clotting, that's secondary to endothelial dysfunction.
The endothelium is the lining of the blood vessels.
Exactly, the smooth, nonstick lining. Cocaine roughs it up, it damages it, which makes clots much more likely to form.
So you're saying the drug literally corrodes the pipes on top of cranking up the pressure?
That's a perfect way to put it. It's a structural breakdown on top of the chemical overload.
And what about cannabis? It's so common now, the potency has gone way up.
Right. And while the sources say it's not a direct cause of cardiomyopathy in big population studies, it's,
Right.
well, it's not harmless.
Not by a long shot.
No. Regular use is linked to a higher risk of AFib, heart attack, and stroke, even in people with no other risk factors. It's definitely on the radar.
That puts a lot of common substances in a new light. But we have to shift now to the biggest cause of all of this:
The most common and probably the most challenging.
chemotherapy.
This is the ultimate paradox. These are life-saving drugs, but they are, without question, the agents most frequently implicated in toxic cardiomyopathy.
So doctors are walking this tightrope.
Constantly balancing the risk of the cancer against the risk of, devastating heart damage. And that risk is influenced by everything: the patient's baseline health, their genetics.
This has actually changed how we classify heart failure risk. There's a specific term you need to know. Just getting these drugs might put you in stage B heart failure.
And that stage B designation is absolutely critical. It doesn't mean you have symptoms. It means the damage has already started.
There are already changes in the heart structure or in the biomarkers.
Yes. The alarm has been tripped, even if you can't feel it yet. It mandates proactive surveillance to catch the problem before it becomes symptomatic.
Let's get specific. Anthracyclines, like doxorubicin. What makes this class of drugs so uniquely destructive to the heart?
They leave a very specific signature of damage. Under a microscope, you see something called vacuolar degeneration.
So the cells are swelling up and dying.
Pretty much. And you also see myofibrillar loss, which is the actual breakdown of the muscle fibers themselves.
And how does that happen? What's the mechanism?
It's a multi-pronged attack. The sources point to reactive oxygen species. Think of it like rust inside the cell. There's also mitochondrial damage, so the cell's powerhouses fail.
But there's a really specific one, right? The topoisomerase 2 thing.
Ah, yes. That's the key technical piece. Topoisomerase 2 is the enzyme that unzips and rezips your DNA for repair and replication.
Like a zipper.
Exactly. And anthracyclines jam that zipper. It causes a catastrophic failure in the heart muscle cell's ability to repair itself, and the cell just dies.
So who's most at risk for this kind of all-out assault?
The risk goes up with age, obesity, diabetes, any pre-existing heart disease. But the biggest factors are the total cumulative dose of the drug and getting radiation to the left side of the chest.
How quickly does this damage show up?
It can be acute, but that's rare. Usually it's picked up by routine surveillance, like an echocardiogram, within the first year after the treatment ends.
And there's a really tricky part to diagnosing it, a nuance that the sources highlight.
There is. Doxorubicin toxicity doesn't usually cause the heart to get really big and dilated, which is the classic sign of heart failure.
So the ejection fraction, that standard measurement of pumping function, might not look that bad.
It might only be modestly reduced, but the patient can still be very, very sick.
How is that possible?
Because the heart muscle is stiff and inefficient. The stroke volume, how much blood gets pumped with each beat, is low. The patient is exhausted, short of breath, even if the EF number isn't terrible.
So the standard test can be deceptively normal.
It can mask severe systemic damage. It's a huge clinical challenge.
Which brings us to a drug called dexrazoxane. This sounds like an ethical minefield.
It is. Dexrazoxane is an iron chelating agent. It can help prevent this type of cardiomyopathy by cleaning up some of that cellular rust.
It's a preventative tool. So why isn't it used all the time?
Because there's a major concern that it might reduce the effectiveness of the chemotherapy itself.
You're forced to choose. Protect the heart for the future, or give the chemo the absolute best shot at killing the tumor right now.
Terrible calculation, a true life or death decision.
You mentioned that the prognosis for this used to be seen as just an inevitable downward spiral.
It was, but thankfully that view is changing. For adults, with really careful management treating any second-hit insults like AFib or high blood pressure, many patients can improve.
But there's a special and very worrying case for children.
Yes. For children treated before puberty, the heart muscle doesn't grow properly later on. This can lead to what we call refractory heart failure, the kind that doesn't respond to treatment when they're in their 20s.
The damage shows up decades later.
A completely different clinical problem.
Okay, let's look at another major drug, trastuzumab or Herceptin.
Herceptin is a monoclonal antibody. It's designed to interfere with a protein called HER2, which is a major driver for certain types of breast cancer.
But HER2 isn't just in tumors.
Exactly. It's also crucial for the heart's own adaptation and survival pathways. So the drug is hitting the tumor, but it's also disrupting a vital maintenance system in the heart.
Is the damage as permanent as with anthracyclines?
Generally, no. It's considered more reversible. However, the sources note it can persist in about a third of patients, and it can definitely progress if it isn't monitored closely.
All right, let's broaden out. We're in the era of targeted cancer drugs now. That sounds safer, But they still have these off-target effects.
They absolutely do. Take VEGF pathway inhibitors. These are drugs that target angiogenesis, the growth of new blood vessels that feed a tumor.
But the body uses those same pathways for other things.
It's what we call biologic conservation. The body reuses the same chemical signals. So when you block that pathway to starve a tumor, you inevitably hit the cardiovascular system.
And what's the most common side effect there?
A rise in blood pressure. It happens in most patients. But what's really striking is that some patients develop severe hypertension and proteinuria. That's protein in the urine.
Wait, high blood pressure and protein in the urine. That sounds like preeclampsia, the condition in pregnancy.
It's an incredible biological parallel, and that specific presentation is linked to a higher risk of future heart problems. It's really hard to diagnose, too, because these drugs can cause leg swelling from local effects, not from heart failure.
So it looks like one thing, but it's actually another.
Exactly, and we see this with other targeted drugs, too. Proteasome inhibitors for myeloma, MEK inhibitors for melanoma, they all carry risks for hypertension, clotting, and heart failure.
It's not just cancer drugs, though. The sources list a whole range of common chronic use medications.
They do. Drugs for rheumatoid arthritis, like TNF-alpha antagonists, psychiatric meds like lithium and clozapine, even some HIV therapies.
But you have to single out chloroquine and hydroxychloroquine here.
Absolutely. Think about how many people are on those for lupus or rheumatoid arthritis. Chronic use can decrease the ejection fraction and cause conduction block.
How does it do the damage? What's the mechanism?
It impairs lysosomal function. The lysosome is the cell's garbage disposal and recycling center.
If the drug jams it up.
It jams it up, so cellular waste and toxic debris just build up inside the heart muscle cells. On a biopsy, you can actually see these inclusion bodies. The cell is essentially being poisoned from the inside.
That's a powerful image. Okay, last category. We've done choice, we've done necessity. What about the toxins we absorb without even knowing it?
Environmental and occupational exposures. The sources point to chronic exposure to things like cobalt, arsenic, lead, and mercury.
And cobalt cardiomyopathy has that really bizarre historical footnote.
It does. Today we think of industrial exposure, but the first major outbreak wasn't from a factory.
It was from beer.
It was from beer. In the 1960s, some breweries used cobalt salts as a beer foam stabilizer. People were drinking it and developing heart failure.
That is just unbelievable. Beer foam. But the risk today is more conventional?
Yes, industrial exposure or, and this is important, from cobalt leaching out of metal alloy prosthetic hips. The diagnosis is confirmed by finding these specific particles inside the heart's mitochondria, a chemical fingerprint. So to synthesize all this for you, managing toxic cardiomyopathy always comes down to two things. You use standard heart failure therapy, of course, but the absolute most critical step is removing the exposure if you can.
And if you can't, like with chemo,
then it's all about aggressive risk assessment and that proactive surveillance, catching it at that stage B designation before it becomes a catastrophe.